delegates, thank you for joining Shield Connect. I am Nishan Chawda, Regional Medical Advisor from Shield Healthcare. It's my privilege to welcome you for this wonderful series, Trending Us series, which is organized by AGOG, Academia of Global Obstetrics and Gynecology on Shield Connect platform. So in this task series, we will be covering the topic from A to Z topics, and today the episode will cover J and K, which will be covering jaundice and kidney disorders in pregnancy. So before we start with the series, let me show the short introductory video of AGOG. And with this wonderful video, let me begin the episode with small Vandana prayer.
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा.
And I am happy to introduce our coordinators for this episode, Dr. Pragna Supe and Dr. Ruchika Gar ma'am. Dr. Pragna Supe Agarwal ma'am is consultant gynecologist and laparoscopic surgeon at Agarwal Heart and Women Clinics in Mumbai. And Professor Dr. Ruchika Garg ma'am is consultant gynecologist at Deepak Hospital, Bogipura, Agra. So I hand over this session to Dr. Ruchika Garg ma'am. Thank you so much.
So a very good evening to one and all. So we are here for a great learning session with all the stalwarts and academicians. So it's my pleasure that this Academia of Global OG episode J&K we are going to start. I welcome all the respected dignitaries, and I have the pleasure of inviting the convener of this session, Dr. Komal Chavan. She is the medical director and is a DNB teacher. She is ex-honorary Professor R.N. Cooper Medical College, and she has got so many awards to her credit, including the latest N.A. Pandit Award, Shelza Pandit Women Empowerment Award, so many awards, and she has been national trainer for so many FOXY projects. And we know recently her FOXY Medical Disorders in Pregnancy Committee got the best committee award, and she is working day and night. She's also our candidate for the vice president of FOXY from the West Zone. So I invite and welcome Dr. Komal madam.
Thank you. Thank you so much, Ruchika.
So I also have the pleasure of inviting Dr. Niranjan Chavan sir. He is a great academician. He is a professor and unit chief, LTM Medical College and Sion Hospital. And he is also held so many posts, including the joint treasurer of FOXY for the current year, from 2021 to 2024. He's President MOGS. So congratulations, sir. He's member of so many organizations, and as we have seen, he's the editor-in-chief of Global Academia Journal of Obs and Gynae. So we welcome you, and sir also has so many awards and publications to his credit. So welcome, Niranjan sir.
Yes, thank you, Ruchika, and I think Ruchika and Pradnya, they have done a fabulous job, and I welcome you all for today's episode of Trending Ask the Expert series. And it is an A to Z series, and today we are going to have J and K. And I think my J and K are already here. That is Jaideep Malhotra madam and Kavita Bapat. So I think the episode is dedicated to them, and it is just a coincidence. But I'm so happy when I saw the brochure and the program being made. But when we talk about J, we talk mainly, there are very specific disorders, and J&K is pride of India. And that is the reason I thought, let's have the two episodes together. And J also stands for Journal Scan. The Journal of FOXY is doing very good. We have our Journal of Global Academia also. And that was, let's share knowledge. That was the idea behind this. And the topics also are focused topics related to advances in pregnancy, that is disorders in pregnancy. And I'm very honored to have presence of Dr. Jaideep Malhotra as guest of honor. And I welcome Madam. Madam is a director of ART Rainbow IVF, president of the Indian Society of Prenatal Diagnosis and Therapy, president of the South Asian Federation of Menopause Society. She has been the president of FOXY, and the tremendous work which Madam has done during her tenure. She has dragged the entire nation into revolution, the Adbhut Matrutva, and her specialization in the IMUMs. Recently, she has also been as an entrepreneur on the television. We look up to you, Madam. You have adorned hats at various platforms, be it Foxy, be it globally. You always make us proud. And above all, she's so humble and such a very good and loving individual. I really remember the visit to your center and how lovingly you have welcomed us all and everything. It is all there in my memories. And Madam, I'm so honored with your presence, and over to you to address the audience.
Thank you so much, Komal. Thank you, Komal and Niranjan both for having me. First of all, heartiest congratulations for all the good work which both of you are doing. It's really nice. And you took the words out. I'm sure Kavita also must have thought of it. I was also thinking J&K, yes, Jerry. Then I looked back and then I saw G, who was G? So then I saw Alpesh Gandhi was the chief guest at that. I said, oh, G also matches if you have not noticed. So it was really nice to, be here. And the amazing topics, because these are topics which are not very well discussed, lesser understood areas for all us. Along with the Liver Society of India, we had come out with guidelines for hepatic disease in pregnancy. And if ever you require, those guidelines are there for everyone to, consider. Because I also try to, look at things and areas which were lesser understood and needed some direction from all of us. I have gone through the program. It's really great. And I've gone through all the previous programs too. All of them very thoughtfully selected and great speakers. So I wish you all the luck and all the best for your coming elections, and otherwise also for the all good work which both of you are doing. God bless you.
Thank you so much, Madam. Thank you for joining in spite of your busy schedule. And now I take an honor to welcome our guest of honor, Dr. Kavita Bapat. Kavita Bapat is the director of Bapat Hospital, Indore. She is specialized for one-day hysterectomy, and she has been the immediate vice president of FOXY, organizing secretary of the much-awaited AICOG Indore. I think we really waited for the Indore AICOG. It was so well done by Kavita Bapat and her team. She is our FOXY presidential candidate also, and she has won numerous awards, that is healthcare award by Dainik Bhaskar, and many awards to her credit. And I when I remember Kavita Bapat, I just remember learn simply. So I think 2 words are enough. So Kavita Bapat, over to you.
Thank you so much. Really, you have given me a great chance to share a stage with Jaideep Malhotra, madam. Mera to din hi ban gaya. She is incredibly inspiring individual. I always look up to her. And unke sare achievements and successful, she is a role model for many and very impressive and impact, I think, personal also and a professional also. She has given invaluable opportunity. Madam, I don't have words. The opportunity you have given me in a FOXY, I think it's a great deal which you have done, and you are an encouraging person, always supports and guides us. And the most important, I'll continue to work hard to make you proud. It's my promise to you. So the another important thing, the Komal and the Dr. Chavan, you people think तुम्हारे program का नाम ही A to Z and program का नाम ही trending. So you are trending. I think there is nothing more than that. Global भी है, academia भी है, trending भी है, and A to Z. I think you are including everything in the topics and the speaker. See the person Reena Vani and Girja Wagh over there with the Ruchika and everyone. I tell you, This is something incredible. And the topic is really also important. The jaundice and the kidney disease. Look, sare din we talk about some different and difficult topics, but these are the topics. When patient comes, we should have a right algorithm. We should have many more things to do, and we should treat the patient in a right time. So thank you so much, and love you always, Komal. K factor should work. So all the best for you and me. And that's all. And the JNK, it worked very well. I think Jammu Kashmir ki jagah Jaideep and Kavita it worked. Thank you so much for inviting me. Love you. Love you for this.
Thank you so much. And I'm really thanking my chief guest and guest of honor for gracing today's occasion. And now over to you, Ruchika and Pradnya. Let's introduce and start our panel discussion.
So, please show the CV of Girja Madam. Yeah, so we have this panel on jaundice in pregnancy. Dr. Komal will be moderating the panel, and as an expert, we have Girja Wagh Madam. She is a great academician. She doesn't need introduction. She was the past medical disorders in committee chairperson, and currently she is also the vice president of FOXI, and she is joint national secretary of FOXI in 2010. She has so many publications to her credit. She's national mentor for Laksh program for Ministry of Health and Family Welfare run by the Government of India, and she's peer reviewer for so many journals, including the JOGI and British Journal of Obs-Gynae, European Journal of Obs-Gynae, and she's a great teacher. And we have learned a lot from ma'am, from her so many webinars during the COVID time. So next, I would take the opportunity to welcome our panelists. We have Sujata Dalvi Madam with us. She is a senior consultant Obs-Gynae in Mumbai in so many hospitals, and she's also clinical associate for Norsurgi Wadia Maternity Hospital.
Okay, Ruchika, you can go ahead.
Yeah. We have Kanchan Sharma Madam. She is also working in Kanpur, and she's Secretary Kanpur Obs-Gynae Society, and she's president of IHRF of Kanpur Society, and she's also an ART specialist, and she is holding so many posts in Kanpur, and she has so many awards to her credit. Now next, please.
Thank you.
Okay, welcome Kanchan Madam. We have Veera Lohia Madam with us. She's a senior consultant in Janak Hospital and ex-president of Gwalior Obs-Gynae Society, and she's secretary of GOGS. She was in 2018, and she is very doing so much public awareness work. She's member of Rotary Club, Lions Club, and co-founder of Health Plus Club. Welcome, Veera, Dr. Veera.
Thank you.
There. Yeah. We have also eminent gynecologist from Mumbai, Dr. Reena Vani Madam with us. She is professor and head in HBT Medical College in R.N. Cooper Hospital, and she made FOXI GCPR for COVID guidance and vaccination. That was a great achievement during her time, and she is member of President Mumbai Breastfeeding Committee, Core Committee FOXI Violence Against Women. She was also the chairperson of FOXI Perinatology Committee. Welcome, Reena Madam.
Good to be here with you.
And okay, next. So all the panelists are there with us.
Yes. So I welcome all of you. Regards to Dr. Girija Wagh, Vice President-elect of FOXI, as an expert on the panel. And I have real eminent senior panelists. I think they really have seen so many cases of the clinical experience which they have is really very vast. So I'm very happy, and I think the panel would be really crisp and with a lot of take-home messages. So let's start with the panel. Can you see my screen? Start from beginning.
No.
No?
No, ma'am. Yes, ma'am. Now it's visible.
Yeah,
Now it's
But it is not full screen.
Slideshow. Yeah, full screen and
make a slideshow.
Yeah, I'm making.
From beginning. Slideshow from beginning.
Yeah, beginning. Yeah. So I'll make slideshow from beginning, and I think jaundice in pregnancy is. Can you see?
Nahi,
Yeah.
nahi, like,
Aya?
no,
No.
yours. Now it has.
Yeah.
Yeah. So when we talk about jaundice in pregnancy, I know that when we think of jaundice, the patient coming with jaundice, we really become very panicky. You know, if you see a icterus and you can manage other things like anemia, hypertension, PI. But when there is a jaundice, so many dilemmas come. Whether I can manage here, what will be the course? You know, that all things keep altering. Or even if you see an abnormal LFT during a pregnancy, so we should know in the background change that in a normal pregnancy also there would be some changes in the liver function test. There would be spider angiomas or palmar arrhythmia, something which are typical detecting liver disease can be present in normal pregnancy. So my now question to Dr. Sujata Dalvi madam. So LFTs in pregnancy, clinically a patient will come in, a pregnant patient. What parameters do you feel can get affected in pregnancy?
First are the enzyme levels, SGOT, SGPT, that could get little bit altered. Then you have alkaline phosphatase, that also could get little bit altered. You have LDH, that also get little bit altered. Only if you see bilirubin levels little up and down, you need to be little careful. Otherwise, slight alteration of all these enzymatic levels with alkaline phosphatase and LDH could be taken as a part and parcel of a normal thing. Of course, you can always keep patient under observation. And routinely, we don't ask for LFTs unless patient is elderly, above the age of 35, or she gives history of hypertension or history of previous, some of the liver problems in previous pregnancies. These are the patients we ask for an LFT. Otherwise, routinely, we don't ask for an LFT. Yes. Or patient complains of itching, pruritus all over the body. That's why we ask for all this.
Yes, I think that is a very valid point you have put up, that we routinely we are not doing LFT, but definitely in high risk patients or in presence of any clinical sign, we can get an LFT done, and we may find a normal report or an altered report. So, Dr. Reena Vani, generally, like how would you broadly classify the liver disorders or a jaundice in pregnancy?
Thank you, Komal. This is actually a very important concept that we have to have clear, that there are certain liver disorders which are already there before the woman gets pregnant. Unfortunately or fortunately, these women don't get pregnant easily. For example, somebody who has pre-existing cirrhosis or who's having Wilson's disease or a chronic underlying autoimmune hepatitis. But there are two categories which are very important to differentiate because our management plan will be different. There are certain liver diseases which are just coincidental to pregnancy, of which the most important is viral hepatitis. And unfortunately, viral hepatitis, for example, hepatitis E, which has a very low mortality in non-pregnant, can be seriously harmful in pregnancy. But the medical people will keep pressurizing you that deliver, deliver, deliver. So I think in our cases, we have to be clear that this is a disease coincidental to pregnancy. We manage the viral hepatitis first and then look at the pregnancy. Certain other things like gallstones, biliary sludge can be seen in 20 to 30% of normal pregnant women. It does not necessitate surgical intervention in pregnancy. So you have to be a little clear. Certain drugs, Budd-Chiari syndrome may be there. But another very important group is the ones which are related to pregnancy and perhaps aggravated by pregnancy. That's where we need to bite the bullet and sometimes deliver them. These include acute fatty liver of pregnancy, of course, the notorious HELLP syndrome in severe preeclampsia. Certain things are at borderline. For example, intrahepatic cholestasis of pregnancy or hyperemesis gravidarum, where your medical line of treatment can pull her through till she reaches term. These don't necessitate early termination. So hence, we need to be clear about this to have a management plan when she comes to us.
Yes. So we will be discussing all these cases in detail. That is a plan. And when we broadly know the causes of jaundice in pregnancy can be not related to pregnancy, which Dr. Reena has so beautifully explained, and few related to pregnancy. So whenever we see an hepatobiliary disease in pregnancy, the pruritus and the jaundice may be the initial symptom. Then it can follow by an abdominal pain, nausea, vomiting, and The patient, when it comes to you, you see an abnormal biochemical test. And American College of Gastroenterology has clearly stated that trimester is quite a best guide. So you have your patient who is in the first trimester and coming with an altered liver function test. You think of hyperemesis, or if the patient is in the second or third trimester, cholestasis is the common, and HELLP, preeclampsia, and even acute fatty liver may come towards the second half of the pregnancy or in the third trimester. So we really need to know as per trimester of the pregnancy, and these are how the pregnancy related disease may manifest. And definitely the diseases which are very rare, which we are not going to discuss. Now my question to Dr. Veera, how to evaluate any pregnant woman with liver disease? What would be your basic thing when you see a patient having any liver disease coming to you? What will be your approach to the patient?
When a patient comes, we'll first ask her some questions like is she's having fever, anorexia, and any pain, abdominal pain, or nausea, vomiting. We already have in pregnancies, but are they exaggerated here? And what are the color of stools? And any history of drug intake? Is she taking anti-tubercular drugs, anti-malarial drugs? So we can rule out hemolysis in some patients if they're living in endemic areas where there's malaria off and on. So,
yes, history taking is very important. Yes, I agree. So I think you have highlighted so well that history taking is so very important. Before we jump into our investigation, we need to take a detailed history of our patient. Dr. Ruchika, what will be your how examination marks and the investigation which you would plan?
So yeah, we will look for her general examination along with the pallor, icterus, what is her mental state to rule out certain acute fatty liver of pregnancy, and whether she is having certain patches because of certain pruritus, and to rule out certain skin conditions. We will look for those, whether what is the type of pruritus is there. I mean, patches are there. इतना ज्यादा तो नहीं है कि उसकी वजह से स्क्रैच मार्क्स हो रहे हैं. And if it's a case of pre-existing cirrhosis, then we'll look for generalized edema or ascites, and whether the patient is having tenderness in the right hypochondrium because of this liver dysfunction. Liver failure में तो नहीं है, and we'll go for an ultrasound scan to look for the hepatomegaly, and because in HELLP syndrome also there is swelling of the Glissen's capsule. So ultrasound is a must, and to rule out this congenital anemias, also ultrasound is required. So if we get a splenomegaly, we can get an idea, and then to rule out pruritus I mean SGOT, SGPT, normal liver function test, serum bilirubin, and serum bile acids.
So we will come to the pruritus case.
And
so
PT, INR.
Yes, this complete panel is something which we are going to do in the investigation. Yes. Yes.
Alkaline phosphatase normally increase, but the level of the increase will differ. Viral markers are also required.
Yes, so I think let's discuss. Go ahead with the case, Dr. Ruchika. Yeah. So
hepatitis B, C, which are very prevalent nowadays, and really we.
Yeah, so let's discuss. We have a case one, a 25-year-old lady. She's a IVF twins. She comes with severe itching in the 5th month and also itching during her first pregnancy. The fetus died in utero and in the 3rd trimester, no toxemia, and these are the parameters, like how Dr. Ruchika has elaborated all the parameters. So we see a bilirubin of 2.8, alkaline phosphatase slightly raised, the liver enzymes also are little raised, and the INR also is corrected with vitamin K is 1.7, and we see that bile acids are also normal. They are high bile acids. So now what is the diagnosis and differential diagnosis, Dr. Kanchan?
Yeah, first of all, thank you so much, Dr. Komal Chavan, and congratulations to you and best wishes in advance. And thanks, J&K Society for giving me chance and involving me in such a brilliant discussion about the condition like jaundice in pregnancy. There are so many causes as we have discussed. Differential diagnosis as such, there are so many but in this particular case, as we see that the diagnosis goes more in favor of the cholestasis of the pregnancy. As we know, the differential diagnosis we can do with the causes which are because of pregnancy. These are hyperemesis that happens in the first trimester, but in this particular case, because the time is more, so that is ruled out. The second, the most common diagnosis which we can expect in this particular case is cholestatic jaundice of the pregnancy, cholestasis of the pregnancy.
Intrahepatic cholestasis. Yes, you are rightly said.
Cholestasis of the
See, we
pregnancy.
have
Yes,
now got
because
our diagnosis that intrahepatic cholestasis, that is the diagnosis. So now let's have an approach.
in
Dr.
this
Sujata
particular,
Dani, Dr.
in
Sujata
particular,
Dani, yeah.
in this particular
Yeah.
case, can I say?
Yeah, I'll come to you, Kanchan, 2 minutes. Dr. Sujata, how will you approach? Because now you have given us a nice diagnosis. We want her.
Yeah, bile salts are 6 times more than the normal, and
Yes.
she's still in the second trimester of pregnancy, and she's got twins. So she has little long way to go. So we need to treat this basically. So apart from the symptomatic treatment for itching, because bile salts are 6 times higher than normal, it's better to give her ursedocolic acid tablet, that is 150 milligram tablet. You can give one in the morning, one at night. And ask the patient to follow up. You can ask her to use some local application like lactocalamine or Caladryl lotion, which will also give her a symptomatic relief. Ask her to take it properly for about 4 to 6 weeks, and ask you repeat the investigations, liver function test, and you find out whether she gets a relief or no. You can ask her to follow up after 2 weeks and then figure out whether this is working out or no for her.
Yes, I think the management, but particularly the initial management is very important, and then we come to the fetal monitoring. So, Dr. Reena, can you tell us about the fetal implications, what complications we'll expect, and how to go about the fetal monitoring?
So, Komal, there is a serious concern about unexplained intrauterine fetal demise. And as this patient has double high risk, she had IVF, and it's a finding that IVF patients are having a lot more of these placental and other problems. And she's had one previous intrauterine fetal demise in the third trimester. So we need to be careful about the fetal monitoring, and we don't. But she's right now at a gestational age, which is too premature. And what Sujata mentioned about the ursodeoxycholic acid, we actually give 300 milligrams twice a day. It's available, and we've dealt with a lot of patients. And if there is a severe pruritus, you can give her additionally antihistaminic or something along with the local application to help her through. But another thing we should keep in mind is a vitamin K, because there is some amount of derangement of the coagulation function. And so vitamin K correction, 10 milligram intramuscular, 3 doses is something which we routinely give, and a high carbohydrate diet. All this is in fact going to protect the fetus because you're keeping the maternal condition stable. There are various tests for fetal monitoring. Most of them are valid from 28 weeks onwards. This lady is twins. So even if we shift the window, like we take 37 weeks as full term in twins as compared to 40 in a singleton, even then, our various tests like the biophysical profile, NST, or the Doppler need to be interpreted in relevance to the time frame involved. So simple things like fetal movement count and other things should be advised to the patient. Keeping maternal condition stable is very important, and that is the way forward. We will try to pull her through up to, in fact, in twins, not more than 37 weeks, and then consider delivery. And if she has had an intrauterine fetal demise and you know at what gestational age, I would strongly suggest that you consider doing a Doppler, seeing how it is, and consider delivering just before you reach that gestational age. So that these are a few important
Yeah,
points.
I would like to add that the level of maternal bile acids will be very much deciding, and more than 100 is the critical level. So according to the RCOG latest guidelines, if the level of bile acids is more than 100, then in normal singleton pregnancy is 34 to 35. After 34 weeks, we have to terminate the pregnancy. But if the level of bile acids is between 40 to 100, then at 38 weeks we have to terminate the pregnancy. And if it is less than 40, then we can terminate the pregnancy we can continue the pregnancy till 40 weeks, though practically we try to terminate earlier because we never know when sudden fetal demise can occur.
Yes.
And the cause of the fetal demise is generally fetal arrhythmias. And the ursodeoxycholic acid, it does not reduces the perinatal mortality as well as the morbidity. What it does, it just reduces the it provides the symptomatic relief. So ursodeoxycholic acid and our topical emollients and antihistaminics will provide a symptomatic relief only.
But
Yeah,
one,
I
one
agree
thing,
with her. One
deoxycholic
second.
acid,
If
that just dissolve the bile acid and reduces its going into the placenta. So have some reduces some of the fetal effects, bad effects.
Yeah,
So
I agree with her because we give we give that, but you need to monitor the bile acid level.
Bile
In
acid,
case of all,
yes.
in case the levels are not coming down, it's
Yeah.
best to terminate the pregnancy by giving her steroids to the patient and to have a better NICU care, because otherwise you're not
And
going to get anything
Yes,
out of it.
monitoring bile acid is the key here because
Yeah.
and the whole management depends upon the level of the bile
And
acid.
in this
And
case, because she is
dexamethasone-
IVF and twin pregnancy and last pregnancy IUD, so there is a strong prediction for intervention at 37 weeks, I think so. And
That's
we
right.
should discuss with the patient for that.
And
Can
now,
I add something, Komal?
yeah, I
There is
want
one-
dexamethasone can
there is
also
one
be given.
yeah,
There's
Dr.
an
Girija,
there is
our
one
expert
clinical
to add.
important point.
Yeah,
And dexamethasone has also been suggested to be given for reducing the pruritus symptoms also, apart from fetal lung maturity.
I
Yes,
now
yes.
want views of our expert, Dr. Girija Wag, about this patient being a twin patient on progesterone. So, should we continue progesterone, and how do we go about any views and opinion on that?
Asking me,
Yes,
Komal?
yes, Dr. Girija Wag.
Yeah, see, basically, I have a serious feeling that it is because of too much of progesterone load that we are having this early presentation of ICPs, especially in patients who are PCOS, hypothyroid, and you are going for ART pregnancies. But in such a situation, naturally, after 26 weeks have crossed, there is no role in giving her progesterone further, which can be withdrawn. There is no reason why she should continue on progesterone, hence on. It should be taken off.
Should be stopped. Yes. And can she take progesterone in the future pregnancy? What do we advise?
It is best avoided. There is actually, progesterone has a very small window of utility. The rampant use of progesterone for everything and anything should be avoided. We have to be very selective for the patients where it is really indicated. Abhi, I can see that progesterone gets prescribed like folic acid, which is not
Yes.
fair, I feel, because that we have to little careful. Maybe all patients it wouldn't suit, and there are side effects with each type of progesterone that we are using, from dermatosis to liver issues and so many other things. Risk of cholestasis, risk of developing even hyperglycemia of pregnancy. So definitely we have to be a little categorical in using progesterone, and in this patient we must try and rationalize. If it is necessary, then with the due risk we may have to give her the progesterone.
Yes, I think that was really well said. And I think we have completed the discussion and we have so much to discuss. I think rightly said that we really need to know the age of the fetal demise and accordingly plan our delivery. And we go on to the next case, which are even more challenging and interesting. So we have a 30-year-old primigravida, 36 weeks. She comes with labor pain, vomiting, malaise, jaundice. She was treated as a viral hepatitis in a private hospital, then referred to a tertiary institute. ANC period being uneventful, but now the vital look okay, but there is an icterus. There is per abdomen 36 weeks, mild contraction, fetal heart sounds are 128. Patient is in early labor. There is unclotted like the fresh blood in the vagina, which is very classical. And immediately the lab parameters, everything were rushed in. And this is the picture what we see. It is all evident. Her platelet count is 1,20,000, which looks little okay. The bilirubin levels are very alarmingly high. PTK, everything is raised. And we see the liver enzymes also are derailed. The blood glucose level is 60 and the viral markers come negative. Now, coming to a diagnosis, what does this clinical picture looks like? So, Dr. Ruchika.
So here the platelets are reduced and SGOT, SGPT are increased. So we have to make the diagnosis between acute fatty liver of pregnancy and this HELLP syndrome. But here, according to the Swansea criteria, here the blood glucose is also less. Serum creatinine is mildly elevated, and so it could be a case of PT-INR are also deranged. It could be a case of acute fatty liver of pregnancy
Yes.
because
So
Yeah.
I think you are
It's a
arriving
typical
at
presentation of the acute fatty liver pregnancy because hypoglycemia is there. There is coagulopathy. There is reduced antithrombin 3 activity. DIC ज़्यादातर होता है, that is in 80%. Serum creatinine and BUN level, if we see, that is also increased in these cases.
Yes, I think all our expert panelists now agree that we are treating a case of acute fatty liver of pregnancy, and acute fatty liver of pregnancy is something which is really very uncommon what we see. And like I really want to know from my expert panel how many have actually seen a case and managed a case of acute fatty liver of pregnancy, and how. And I think the diagnostic criteria were discussed by Ruchika. But what were the classical signs and symptoms, Dr. Reena or Dr. Sujata?
No, I have not seen it.
in
But
our
they're
medical
well
college,
managed
so
with
many
IQ.
cases of acute fatty liver in pregnancy come.
Yeah.
In medical college, they come with loss of consciousness, totally ectric conjunctiva, and blood urea
So
nitrogen are
Komal,
increased.
In ultrasound can also guide us in acute fatty liver, isn't it?
Yes.
Komal, one
Yes.
important point. Now, I have worked at Nair Hospital for 21 years, which was associated with Kasturba Institute of Infectious Diseases.
Yes.
What was the problem is that sometimes, a lot of times, acute fatty liver of pregnancy is not diagnosed. It is labeled as hepatitis and they land up. So I have seen quite a few cases in our career in Nair and Kasturba, not so many in Cooper, but the key point is identification. And for that, you have to have your mind open that this is a diagnosis. And sometimes people consider it as a non-proteinuric HELLP syndrome. You know, like when you have a normotensive patient with this kind of picture, you don't think of HELLP otherwise, but it could be a non-proteinuric HELLP. So the criteria to diagnose is very important. And for that, you have to be prepared. But having said that, what is important is for whether it is HELLP syndrome or whether it is acute fatty liver, what is our management plan? It is early delivery. So that so nobody should feel small, oh, I missed this case. As long as you have delivered her fast, that is very important. In fact, I have seen one patient who actually needed a liver transplant because of the necrosis of the liver. In acute fatty liver pregnancy, the ultrasound may show the liver to be a little shrunken. And one more differential diagnosis is a liver hematoma. Now, these things, normally when we are doing an obstetric ultrasound at 36 weeks, we don't ask for an abdominal ultrasound. So a small clue for our clinicians is to specifically ask your radiologist to comment on whether there is free fluid in the abdomen and what is the status of the liver. Unless you ask for it, they will not scan. And this will help you in your management plan for her. For example, if this one is a HELLP syndrome and she's a primey, she's not delivering, or even if she's AFLP, you want to deliver her soon, you do a section. You have delivered the baby, but there will be continuous trickling. You don't know where the blood is coming from. So these are the cases where your ultrasound having been done earlier. And of course, we correct the DIC with the INR of 3. I would correct the DIC and deliver her.
First of all, we will give we will give fresh frozen plasma.
Yes.
FFPs.
and plasmapheresis.
Yeah, so we know now that coming to a diagnosis is so important, and we have this Schwann's criteria, and all these 6 out or more of this, if it's present, we come to a diagnosis of acute fatty liver. And as Dr. Reena has so rightly pointed out, that we sometimes don't diagnose because of the overlapping of the symptoms, and they are sometimes misdiagnosed, and that is very, very important. So, and also the infant born to the mother, the pathology is that these infants have then have they have LChat, that is LChat deficiency, that is actually a pathology which is associated, and that crosses to the mother, and they causes the dilated cardiomyopathy and progressive neuropathy. So this is how the acute fatty liver of pregnancy, they have some mutation or a gene which is mentioned. So we just need to remember that this is a retrospective diagnosis, but really we need to diagnose with Schwann's criteria to allow at a symptom to diagnose. That is very important. And one of the differential becomes a HELLP. So these are just a point put, but I really want experts, Dr. Girija or somebody, to tell us, how actually we can diagnose HELLP and rule out acute fatty liver by the experience and how the patient presents. Dr. Girija or Dr. Sujata?
Komal, one important point here is the LDH level.
Yeah.
The LDH level of below 600 goes more in favor of a AFLP, whereas in HELLP syndrome,
Yes.
the LDH is usually elevated.
It's very, very high, yes.
One important thing. And of course,
Platelet count is very important.
Platelet count decreases in HELLP, whereas in ALFP, the platelet count more or less would remain the same, or maybe it is more than a lack of
It will
it. So
decrease
these
in the
are
advanced stage, yes.
correct. So that's why it's mainly the platelet and LDH levels
And
which will help
moreover,
differentiate between HELP and
Another
AFLP.
thing is
and the patient will be swelling
ammonia.
edematous in case of HELLP syndrome
Yes,
generally.
and correct. Whereas in
Patients
ALFP,
look.
yeah, we will not get that. So these are mainly
Hypoglycemia is another thing.
Hypoglycemia and ammonia level. These two are again an important point.
PBS, peripheral blood smear will differentiate these two conditions.
Yes.
Histiocytes will be present with HELLP, while AFLP won't have histiocytosis.
Yeah, helmet cells. Yeah.
Yeah, schistocytes present will tell us that there is a hemolysis, severe amount of hemolysis which is there. So this is all how we need to keep our antennas open and rule out differential HELP when we are knowing, because if we start managing as HELP, maybe the management is same, but the parameters which are affected, you see that you may require a platelet transfusion in a HELP, but acute fatty liver may not require.
That's
Yes, that is different. So the team, I think the management is the key. I think most of it is discussed by Dr. Reena. Anybody wants to add about the management of acute fatty liver? Dr. Sujata, Dr. Ruchika?
No. I think addition of vitamin K needs to be a multidisciplinary approach, and in an ICU, you cannot handle it anywhere else,
Yes.
We have to be conscious and follow it regularly. In case there is any complication, that should be immediately referred to that particular unit.
Yes. Dr. Veera, you want to add, or the management?
In further pregnancies, we need to see this deficiency or the genetic disorder that is causing this.
Yes, so we will have to be vigilant in the future, but we really have to prevent a near miss situation now. So we will, yes, so PPH and other things. Yeah, so we will definitely keep everything available for PPH. The pregnancy management itself with correction of coagulopathy and minimize trauma and everything, and be prepared for PPH.
Yeah, blood and blood components.
Yeah, so we have 15 minutes, let's rush in. The next case is a 28-year primary gravida, 26-week with preeclampsia. She is having the blood pressure of 150, 110. Icterus, she presents with icterus pedal edema at 34 weeks with mild contraction. Fetal heart sounds are okay, 144. She is in early labor, and this is a lab parameters. Now we all know how to differentiate between the two parameters. I know that everybody must have guessed it. The platelet count being low, the bilirubin is high with the
HELLP syndrome.
HELLP syndrome.
So she is going into HELLP syndrome with viral markers being negative. And we all know HELLP syndrome. I will request Dr. Veera or Dr. Sujata just to summarize how to go about and managing the HELP, because it becomes confusing when we get in our practice, we get a HELP syndrome patient. We really are confused whether to deliver the patient, which
multidisciplinary approach has to be taken. She is to be admitted in the ICU, and we have to take care of her state of DIC first, and then plan as fast as delivery we can do, because fetal mortality is also there, and maternal mortality is also there. So the LFTs and other things has to be taken care, vitamin K, and prepare for the platelets transfusions, and then terminate the pregnancy as soon as we can do.
Yes. So this is the classification of HELLP, whichever this is a complete syndrome. And there are something incomplete also, where one or the two elements will be there out of HELP. So I think that unusual or atypical HELP also is seen nowadays. And we really need to diagnose them also and manage. And this is the reference of the Mississippi's classification according to the platelet count, liver enzymes, and the LDH levels. So this is the diagnostic criteria.
Just add one thing. It's really important that we do a multidisciplinary approach. But what we must remember is our medical colleagues will not be the right persons to decide when to deliver. And one important thing is if the platelet count is less than 50,000, we cannot attempt a vaginal delivery because the baby will have intracranial hemorrhage. Plus the issue of how to deliver. So even though she may be in the medical ICU, the decision of when and how to deliver has to be taken by us, with the medical team as a backup. Blood bank is very important. Blood component therapy. Of course, nowadays nobody should be whole blood, but component therapy should be available. Give steroid cover, correct the coagulopathy, and stabilize the blood pressure, deliver her. Again, magnesium sulfate for neuroprotection is important in these cases also, especially because it's a premature delivery that you're planning. She's, of course, this one is around, you said 36 weeks, so that's not important in this case, but in somebody who's more preterm and you need to deliver. So I think these are important points, and be careful during the section to look after every small bleeder, because when you correct the coagulopathy, these are the patients who sometimes land up with a rectus muscle hematoma. In fact, this is one of the few indications where I prefer to take a vertical midline incision to open the abdomen, because the chance of missing a small bleeder and quick entry, quick exit from the abdomen is possible. Of course, it's a personal choice of the surgeon. These are a few tips which I wanted to suggest.
Yes, I think when we are planning an operative delivery, we need to take all the precautions. If the patient is getting good contractions, she is near term, more than 34 weeks, definitely immediate delivery needs to be done. But if she is little less, like as the guideline says, around 27 to 34, we can just stabilize the patient, try steroids for fetal maturity, and then deliver. And really important is to prevent the intracranial hemorrhage even for the at the vaginal delivery. So cesarean would be, because if the bishop score also is poor, would be a safer option, but it will come with lot of other implications, as in small bleeders. There will be bleeders. There would be a non-specific bleeding, and the surgical time also can get prolonged. And the anesthetist also would not be comfortable giving a regional anesthesia in presence of the platelet count being low and the patient under general anesthesia. We are worried about the bleeding. So what about a drain, Dr. Krishna? Will you be comfortable putting in a drain for such a patient during LACS?
Actually see the points, whether if you are this is a surgeon who can decide whether there are small bleeders. Still, if you feel, you can put very well a drain and
like,
take it out.
Is anybody putting? That is my question. It's like, are you all routinely using a drain for the HELLP syndrome patients?
Not
So,
routinely.
No, not routine.
Depends on patient. But it's
Unless-
always safe to put whenever we are in tension. I mean, it's always safe than not putting the drain.
Yeah, unless
So
patient
here-
is very obese. If patient is very obese, and it's worth putting it at least, in the abdominal wall or anything. Unless you're surgically, it's
Only
not
then.
very clean, then you can put it. Otherwise, there's no need to put in a drain if you're surgically quite well, hemostasis is achieved.
We should provide blood components. We have to correct the DIC if we have transfused
now
enough of
there's no point talking about
FFPs.
surgery.
Komal, I would like to just specify, if you're putting an intra-abdominal drain, it is important to put it if the patient already had a component of ascites along with blood-stained fluid. Otherwise, as our co-panelists have said, if your hemostasis is good, you need not put. But if you're putting a drain, don't put Romovac. Put a proper cortex tube or a tube drain in the abdomen. And if you've taken fan steel, again here I emphasize that I usually take vertical in an impending DIC. But if you're taking a fan, you're putting in the subcutaneous or abdominal wall, that's where you use your Romovac drains. Otherwise, in the abdomen, if you're putting a drain, it has to be a good wide bore tube drain. Otherwise, there's no use.
Yes, because the incision is according to your comfort. I think we can take a vertical, but you can take a fan and steel also. And drain, if you really have a doubt of any hemostasis, I think you can put in a drain, because again, collection, and when they are in DIC, and sometimes this patient go into DIC, fulminantly. So they may bleed from all the sides, and there may be an intra-abdominal collection. So if you feel the patient is in DIC or any other complication related to HELLP, then you can think about putting in a drain. But generally, if everything is all okay, drain should not be put, because it can be a focus of infection also later on.
That's
Yes. So, Dr. Girija, you want to add anything in HELLP? Our expert, let's have our view from expert.
What are you asking me about, Beta?
We have discussed about the HELLP. So, what about the management, like the management of HELLP, operative delivery, how to go about the the requisites, and we were discussing about the hemostasis and drain and other.
There are two controversial things which I'm going to say about HELLP syndrome. One of them, because none of them are being yet time tested, but in clinical practice, we find that they help. And one of them is giving magnesium sulfate, the same magnesium sulfate dose as we go as Uspan regimen, which has been used for neurotoxicity. There are a few studies which are coming up that it will help us in stabilization of the pancreas, the liver cells, and prevent apoptosis, which is the common metabolism, or improve liver perfusion. Now, this is something which has to be weighted against many things. If the HELLP is an antenatal diagnosis, swift delivery after stabilization of blood pressure is a better call to take, always to be taken. And if many times HELLP gets diagnosed post-delivery, or it emerges post-delivery after the baby is born, and then you may have to take recourse of trying to do symptomatic treatments for these patients. The second thing is steroids. Again, that is the second controversy. Usually the same steroid dose which we use, the dexamethasone has been proposed, which we use for lung maturity, that is supposed to be, is also proposed in some studies being used for HELLP syndrome. And all these required to be individualized, because management of HELLP syndrome is a multidisciplinary approach. And we all are very absolute expert and experienced people. But many times for treatment of certain patients, we require to have a good infrastructure and a supporting system. So HELLP is one of those diseases which can completely recover or sometimes take a very, very bad turn. And therefore, it's always better to be treating it in a institutional-based management. And be aware, because this hemolysis can sometimes occur in the form of a wave. Suddenly, a woman will start looking yellow and she will have sudden hemolysis, which can really take a huge toll on your management. We have to be looking for, especially if the patient has delivered, there can be sometimes bleeding from undetermined sites, like we may not be able to understand. It's not only the atonic PPH, but there can be hematomas, there can be vulval hematomas. So we have to be very careful. Many times patients of preeclampsia have been mismanaged because these sites of bleeding under the muscle bed in the abdominal cavity or inside the vagina have been misdiagnosed or have been missed. And then they have landed in complications. So whenever we are looking at HELLP syndrome, try to look for everything, like how Dr. Reena was saying, that you must get into the habit of requesting for an ultrasound, not because it's actually the duty of the radiologist, but you are the primary caretaker of the patient. So it doesn't take more than a sentence to write on the requisition that the patient please do a evaluation of the liver. You can also look for portal hypertension, any ascites, any bleeding, because these are going to go a long way. At one point, Komal, there was a time in the beginning of, we used to have a lot of differences with our physicians about certain things. The moment we used to deliver a severe preeclampsia patient, she would come 48, 72 hours after that into the ICU round and used to say the patient is bleeding inside because something has happened. And then, she used to turn anemic. And then we used to consider, do we need to re-explore? Is she bleeding inside? And sometimes we did take a call if the patient was not hemodynamically stable, and these patients don't take this reopening very, very, very happily. So what we decided to make a modification was, that time we used to put drains after a C-section in such patients where the hemodynamic stability, especially the hemostasis, is questionable. We used to put drains in those women so that would give us a little respite. Then things changed a little better because we started using FFPs, and then we started using magnesium sulfate. We use it quite rampantly for HELLP. Vitamin K, this is a very valuable injection. You can give vitamin K to these patients because that can help in controlling bleeding. And I have been, seen sometimes when you go and see neurosurgeries and all, they're putting a lot of hemalock and everything in certain spaces. So be very cautious about this bleeding. Finally, we should not forget the fact that we are surgeons and we must try and achieve hemostasis. And we have to ensure, especially these are the cases which really demand a lot of expertise from us, where we should try to look for all the related issues and accordingly treat our patients.
I think very valuable inputs and everything. Now my only thing is that when should we transfuse platelet? At what level of platelets? Platelet transfusion we know we need to do, but now there are various guidelines. When we talk with the transfusion or a hematologist, they are okay even at 20,000 platelet count. We had a meeting of obstetric hemorrhage with hematologists. They were saying till 20,000 you should not do anything. But what do you think? What is the opinion of the panel?
20,000 you should not do anything means, see, depends on the condition of the patient. It's not about only 20,000 platelets. 20,000 platelets, thrombocytopenia is known, and these patients don't bleed. We have done even hysterectomies in this patient, like, even vaginal hysterectomy or things like that. The thing is that platelets, very low platelets, your anesthesiologist will not give a regional anesthesia, will choose a general anesthesia. You will not be able to give an epidural, that is one. Intramuscular injections, you may not be able to do. So these things you have to remember. And secondly, if at all you have to give platelet transfusion, that is only given in the face of an imminent bleeding. So if you are delivering her or if you are doing a C-section, only for that time you may have to give her platelets. If possible, try to give her single donor platelets, which is not a very easy thing to get, however. And then you definitely have to keep on putting on a continuous coagulation assessment to understand whether you require to use other component therapy. It's not only about giving platelets, platelet kam ho gaye, udhar se replace karo, because these cells don't last in the circulation for more than 4 to 6 hours. They just give you a temporary respite, whatever. And today life has changed. If at all you have an access, I think maybe after we finish our practice only, Reena, this will happen, that we can have thromboelastography, which can keep on giving us the dynamics of the and we can use. I think Reena wants to say something and about this platelet.
Yeah. So Girisha, I agree completely with you. There's one or two important points that we have to remember. That the platelets will, 1 unit of platelets will raise the count approximately by 10,000 only. So if you're giving platelets, you usually have to give 6 to 8 packs of platelets. And they only last, as Girija very nicely mentioned, you have to give it when there is acute bleeding or at the time of intervention. For example, if you're taking her up for section, there is no sense in giving the platelets 2-3 hours prior to it, waiting for the INR and then doing the section. You have to give it just in pre-op or intra-op. That's when it works best. And single donor platelet is, most of the blood banks will be able to mobilize it for you. That is, but it's more expensive. So if the patient cannot afford it, that's when we go for the random donor platelets. So I think these are, yeah. And thromboelastogram, I'm happy to say, is available in quite a few places, Nanavati, Nidavati Hospital, and it gives you a good clue. But again, it's very costly. It's 10,000 rupees to just get that report. So it's better to spend that money. I'm at a public hospital on getting the patient blood products.
And I think you can take a wise advice from a hematologist. There is no harm in consulting a hematologist who can guide you, online. Many of them do it. They're happy to guide you with what kind of transfusions you need to use if you are not able to find your own way out of this.
In the end, such cases can be dealt with in tertiary care centers only, where everything, blood products and everything are available.
So we generally try to make good her coagulopathy by transfusing FFPs in the ratio of 1:4. I mean, 4 units blood to 1 unit FFP. Then if the
No,
coagulopathy is
no.
corrected, then the chances of bleeding and oozing from all sides is very much reduced. So platelet transfusions, as the hematologists, they say at our center also, and at our center, most of the cesarean at platelet count less than 50,000 are done under general anesthesia only, because the anesthetists, they never take the risk of putting epidural and spinal for such patients.
Ruchika, I would
And
like to differ on one point. What
yeah,
you mentioned is we also use a lot of FFP, but the ratio of blood to FFP is actually usually 1:1 in a patient who is like this. Or in fact, sometimes I give 2 FFPs for every unit of blood which is transfused for these patients, and that's what is recommended by our hematologist. Minimum 1 FFP for each blood if you're not giving your platelets and other things, because that is something which helps the patient. And in fact, you have to be vigilant in the next 24 hours after the section also. It is not enough that you had hemostasis at the time of cesarean, all is well, you have closed. The next 24 hours also, you may need to give more blood products and FFP. And usually it's a rule of thumb, we do the immediate post-op hemoglobin and the PT-INR. And if required, if you're giving blood, we always give FFP along with that post-op also. So we deal with a lot of these cases, and that's what we do.
Yes, usually 1 blood and 1 FP.
but in various guidelines, it is differing. In various guidelines, it is differing. Many of the guidelines are saying this. There are many publications also.
All critical care specialists now go for 1:1:1.
Yeah.
Yeah.
Yeah, most of the critical care people go for 1:1:1.
आंटी तो वो बारीक बारीक काटे थे इसको क्यों काटे फिर आपने?
Okay.
I think we can go to the next case, Komal. We've discussed this in. I think we are running out of.
It's already 6 o'clock.
Yeah.
86. You are muted. You are muted. Dr. Komal, you are muted.
Yeah. So I think we'll go on to the next case. And Dr. Reena had earlier highlighted about the viral hepatitis at the initial. So we have a 30-year-old Gravidas 2 para 1, single gestation. She's coming with anorexia, nausea, vomiting, jaundice, and she's in the 7th month of the pregnancy. She's transferred from another hospital, and the patient has a deep icterus. She's conscious, but she has generalized edema. We can see the liver enzyme exponentially very high. The bilirubin is around 25. The RBS is 60. The ammonia levels are very high. The platelet count also are low. And when there is albumin count also is low. WBC count is 12,000. And hepatitis E IgM is positive, and rest everything looks okay. There is no chronic liver disease. Fetus also is normal. So now we know we are treating a patient of hepatitis E. So now she's come to a critical care unit or a tertiary institute. I think Dr. Reena or Dr. Sujata, she's come at Badia or Cooper Hospital. So where will she get admitted first?
So, Komal, I think Sujata has put a message. She's had to leave for an emergency. Okay. But what I would like to say here is, first of all, she needs to be admitted, if possible, in a medical ICU. But you have to manage her conservatively. The medical people often say, deliver. But this is a classical case where you want to stabilize the patient, try to tide her past. If she does not have any signs of other maternal deterioration, if she gets past this critical time, she will be much better off. The only one thing you have to be vigilant about is that make sure that the sugar levels do not keep fluctuating, because that can be associated with intrauterine fetal demise. So I have dealt with a lot of these cases in my experience at Nair, and even if, when they come to Cooper, if it's an infective hepatitis also, we and the viral marker comes, hepatitis E is something we have to be very vigilant about and stabilize the patient. And before monitoring is also very important. An obstetric point of view, be patient and monitor as long as the fetal well-being is all right. You can wait until she's in a better state and pull her through to 37 weeks.
I think the obstetric thing is only the monitoring. Anybody wants to add anything? We need to just monitor the patient on obstetric point of view and not to intervene at this stage, because this is completely a medical illness. and we allow the patient to come out of her clinical, the disease, and then you just monitor her pregnancy. That is the bottom line. What is the management guidelines go on. I think somebody wanted to add something.
The viral load is also very important in this case. So viral load can be seen in this particular case. Except monitoring the obstetric point of view, that is very important, but viral load should be seen.
Yes, I think viral load, if you get, you will know if it is developing into fulminant hepatitis. So knowing the viral load is important, and these patients land up with fulminant hepatitis, may require a liver transplant also later on. I think this all was discussed, and we really have little short out of time. So I think we'll just wind up, and I will just take some messages from all the panelists. I think Dr. Veera, Dr. Ruchika, Dr. Kanchan, Dr. Reena, and Dr. Last our expert, Dr. Girija.
Yeah, thank you, Dr. Komal. We have discussed quite many cases. So the liver disease in pregnancy is the diagnosis criteria is the exclusion criteria. You have to exclude the signs and symptoms and the laboratory test, seeing the bile acid bilirubin level, and through ultrasound, through the INR, PTT, all but the exclusions criteria we meet, viral markers, we can reach up to some diagnosis, and management will depend on that.
Yes, Dr. Kanchan.
Yes, the viral disease, liver disease with pregnancy is very important. The diagnosis we reach on the how it develops, whether this is in the first trimester or the second trimester, what are its condition, like what is the serum bilirubin level, what are the different liver enzyme levels, what is the platelet count, what is the hypoglycemia, what are the other investigations, that depends how we reach on the diagnosis, whether there is a pruritus, itching, and after reaching the diagnosis, we can do accordingly management. The patient is hypertensive, having the HELLP syndrome, and all other. Accordingly, we can manage.
Yeah, so the critical level of bile acids for obstetric cholestasis is more than 100. So maternal monitoring should be done with bile acids follow-up after 15 days or according to the level of bile acids, and fetal monitoring is very much required to avoid sudden intrauterine deaths and fetal demise.
Dr. Reena, any take-home messages?
So, two important take-home messages. Generally, for all liver disorders, high carbohydrate diet, lactulose syrup, having the clear bowel, and coming to a diet. Second important point is find out whether it is a disease which is aggravated by pregnancy. If so, then you intervene. If not, be patient, wait, stabilize. That's my message.
And one thing we must repeat, lefties weekly, I think, in such cases. So we'll know whether it is aggravating or not.
Yes. And last, the message from our expert, Dr. Girija.
You are muted.
Yeah. To unmute, madam.
So yeah, basically it was a wonderful panel discussion, and I know with all experts such as Dr. Veera. Veera, hi.
Hi.
Yeah,
nice to see you.
Around, I think there was a wonderful understanding that we have been able to share. But liver diseases keep on taking our googlies, and therefore we have to be there always understanding these things. And liver belongs to us all the while. You should not say that somebody else will make a diagnosis for you, because sometimes, even in a multidisciplinary care, you must always discuss across the table so that you are right on hill to make the correct treatment choices for the patient, because finally the women and the baby's life counts. And currently the biggest concern is the rising ICP levels is very, very high, and even the HELLP, and therefore we have to be a little on guard. And pre-pregnancy optimization of health, not forgetting to give at least those preventable vaccines against hepatitis, which can be given, should be definitely practiced, because that can help us in at least reducing hepatitis B, kind of liver afflictions. And in some places where it is a sort of an regular occurring disease, you can consider giving the seasonal hepatitis vaccinations, because that will definitely help these women to overcome these complications.
I think excellent messages by each one of you, and I thank all the esteemed panelists, our expert, Dr. Girija, Dr. Reena Vani, Dr. Sujata Darvi, Dr. Veera, Dr. Kanchan, Dr. Ruchika. It was a fabulous panel, and motherhood is the greatest thing, and it is the hardest thing. I know patients with liver disease really struggle very hard to get this joy of motherhood, and we are really going to make it as the easiest thing for our patients. And just a humble appeal, this slide comes after all presentations, and I require your vote and support for the post of Vice President
Best
of
of luck,
Committee.
Dr. Komal.
Yeah, thank you so much. And there are few of my colleagues also who are going for the chairperson's post, and they have also joined today. So I wish all the best to all of them who are aspiring for various posts.
Dr. Anita, Dr. Kanchan, they are for
Yeah,
chairperson.
yes, Dr. Jairani also is there.
Yeah,
So best wishes to all of them. And thank you so much. It was a wonderful discussion. And I hand over to our coordinators, Dr. Pradnya and Dr. Ruchika.
Thank you.
Thank you, Komal. It was a great discussion and it's a pleasure to be here. And I'm sure our obstetricians will do a better job than the medical people handling things.
Of course. Yes.
It's always better that we look after the patient, because we see as a whole the emotional touch that always matters. The physician always will know what to do, and so on. But for us, it is more a commitment rather.
Yes. Thank you.
Thank you so much, madam. I think it was such an enlightening panel discussion on jaundice in pregnancy. So after that, we move on to our next session. Our chairpersons for next session are Dr. Deepak Bhagde. The sir is past president SOGOG. He's also head in Department of Gynec, MP Shah Medical College, Jamnagar. Welcome, sir. Our next chairperson is Dr. Anita Rajoria. Madam is HOD and Senior Consultant, Department of Obstetrics and Gynecology, Dr. Hegdewar Arogya Sansthan, Government of NCT of Delhi. Madam also is the founder, Vice President of Delhi Gynec Forum, past chairperson of Reproductive Endocrinology Committee, and she has a number of awards to her portfolio. So welcome, madam. Our next person is Dr. K.S. Jairani Kamraj. Madam is Senior Consultant of Reproductive Medicine, Director, Akash Fertility Center and Hospital, Vadapalani, Chennai. She's President, OGSSI, Treasurer, TAPISA, and she also has a lot of awards. Welcome, madam. Our next person is Dr. Shefali Jain. She's infertility specialist from IIM Indore. She's recipient of the Ojaswini Award for outstanding work in the field of infertility. Welcome, madam. I now request our senior most chairperson, Dr. Deepak Bhagde, sir, to introduce our first speaker, Dr. Munjal Pandya.
Thank you very much, Pradnya, and thanks, Komal, for getting me into this wonderful panel and the wonderful web meet. Yes, I could join very late, but it was really wonderful listening to the panel and the expert comments by Girija and Komal also. What do I say about a person who himself is an academician at the best, is absolutely a good photographer. If you really require your profile photographs and everything, just sketch all Dr. Munjal. It's not only the photography, you know, it is even his writings in Gujarati. If you see the poems, the literacy level, what he has. And, you know, I'm always feel proud about the literate people in the sense they're writing books and they're managing the practice also. Academically, very sound, associate professor, recipient of many awards. The limelight being the Kamini Rao Yuva Foxy Shirish Daftari Award, and being the secretary of Ahmedabad Society. Munjal being a good friend, a good young colleague. Welcome to this, and I'm sure you're going to do justice to a difficult topic, I would say, you know, a really difficult topic, a very unusual topic, but I'm sure with your insight, we are going to enjoy it. Thanks.
Thank you so much, sir. Thank you so much, sir, for those beautiful words. Actually, more of encouraging words. And basically, I'm going to cover this topic in form of a journal scan. It was not such a difficult task because there are very few articles on this published having some message that is being passed on. I have taken recent articles. The most recent is like 2021-22, and the the last, I mean, the one which is oldest is from 2019 year. So to begin with, I have taken actually 5 of the articles, more of review articles, having covered almost everything that this topic has. And I would like to have opinion of experts at the end of it as well. I would try to cover it in 10-15 minutes, just to highlight the salient features of every article that I have taken along. So to begin with, we know that the first pregnancy, which was successfully, delivered in a kidney transplant patient, happened in 1958, and then on there is like pregnancy, a normal phenomenon when the rest of the factors with regards to maternal and fetal aspect are covered and are under control. Pregnancy will have an optimal outcome for mother as well as fetus. In patients with chronic kidney disease, they say that there is impairment of fertility for various reasons, for various medications, but after renal transplant, actually the ovulatory cycles or the menstrual cycles would resume within 3 weeks, and HPO axis will start functioning normally by 6 months. So pregnancy is possible in patients having kidney transplant. We know, just a second. There is a bar coming in. I hope it is not visible to the audience. Okay.
No,
so
it's
we know
clear.
Okay.
Yeah,
thank
it
you,
is clear this side, Munjal. Yeah.
Okay, thank you, ma'am. So basically, we know the complications related to fetus as well as mother in patients having kidney transplant. There are major risk of infections because this infections will be detrimental not only to the fetus but also to the mother. Immunosuppressive medications and teratogenic effects are always a possibility. Preterm birth, small for gestational age fetus, growth restriction and malformations are common because of the immunosuppressant medications they are on. Spontaneous abortion and intrauterine fetal death are again common. Cesarean section delivery majorly limited to the obstetric purpose, but nowadays on maternal request and out of apprehension of mother as well as the couple, CS would be necessary as well. Rejection and graft loss are majorly not dedicated to pregnancy alone, but there are other factors which would lead to rejection or graft loss and which would again have detrimental effect on the pregnancy and fetus. There are more chances of preeclampsia because the mother who is having renal transplantation done might be having hypertension beforehand as well because of renal origin. And that is why this mother is going to, or more likely to go on to preeclampsia or eclampsia. The disease progression might lead to development of chronic kidney disease. Proteinuria will be more as compared to normal healthy pregnant females. Worsening of hypertension will be there because of vasoconstriction of afferent and efferent tubules. Hypertension and diabetes are common. Again, as well, pre-existing diabetes and pre-existing hypertension will have detrimental effect on mother and fetus. So pregnancy outcomes after kidney transplantation was the first paper. It was published in 2021. They actually had the research work of 24 pregnancy from 2013 to 2020. The aim of this paper was to examine the course and results of pregnancies after transplantation, the effect of pregnancy on graft functions and risk factors in complications. So results were the mean age of this patients was around 31 to 32 years of age. Mean time or interval between transplantation and pregnancy was around 54 to 55 months, which is actually beyond 2 years, and which is the actual recommended interval between transplantation and pregnancy. Mean newborn weight was around 2 kg. There was 1 case of abortion out of 24 pregnancies. There were 17 preterm deliveries and 10 IUGR babies. And median serum creatinine level was increased significantly in 6 months in all of the pregnancies. Urine protein increased significantly in 3rd trimester, which again reverted back to normal, at least by 3rd postpartum month. Kidney transplantation versus dialysis was compared as well. When it was compared with dialysis, kidney transplantation patients had more or higher level of quality of life, better health level, and more pregnancy success and much better prognosis as compared to the patients who were on dialysis. The probability of giving healthy birth or live birth was approximately 1/10 as compared to healthy pregnant female. Risk factors which needed to be eliminated before planning for pregnancy were arterial hypertension, proteinuria, adjustment of immunosuppressant therapy. And maternal complications were found which were increased in these patients were gestational hypertension, preeclampsia, GDM, and adverse fetal outcome were more common as compared to the healthy pregnant females. And risk of impaired kidney function was lower when creatinine level was less than 1.5 milligram per deciliter and in absence of hypertension and proteinuria. So these were the favorable factors for better maternal as well as perinatal outcome. Timing of delivery, so timing of pregnancy, as earlier mentioned, ideal duration between transplantation and pregnancy is 2 years, majorly for two reasons. One, the immunosuppressant agents which are aggressively administered within first 2 years of transplantation has teratogenic effects. And second one is adjustment of the doses of immunosuppressant agents would take at least 2 years, and then you can plan the pregnancy. No increase in graft rejection except for sensitive pregnant patients. And in this particular study, no patient was found to have graft rejection. Tacrolimus was one of the immunosuppressant agents which was basically used in all 24 pregnancies. The serum level was maintained between 4.5 to 7 nanogram per deciliter during pregnancy, and UTI during pregnancy had increased risk of birth complications in form of preterm births and IUGR. So the conclusion of this study was pregnancy does not have any significant effect on maternal and fetal survival, graft rejection, and graft function in pregnancies with kidney transplantation, but complications such as hypertension, preterm delivery, and low birth weight were high. The second paper was acute kidney injury during pregnancy in kidney transplant recipients. It was again a review article. It was published in 2022. The higher adverse outcomes like preeclampsia, preterm births, and allograft dysfunction were noted in patients with kidney transplantation. Diagnosis of AKI remains challenging because the criteria are still not so firmly made. And incidence of pregnancy-related AKI has increased threefold in developed countries, majorly due to advanced maternal age, increased comorbidities, and lifestyle diseases like hypertension, diabetes, and obesity. Effect of pregnancy on allograft function. So kidney allograft basically adapts to all the physiological changes that happen in mother. Creatinine clearance increases by 30% in first trimester. It gets decreased, slight decrease in second trimester, and return to pre-pregnancy level by third trimester. Among females with CKD stages 3 to 5, gestational fall in serum creatinine of less than 10% in pre-pregnancy level, along with chronic hypertension and proteinuria, were associated with adverse pregnancy and kidney outcomes. Increased GFR was already there, but in this patients, it will lead to more 24-hour urinary protein excretion. So protein excretion in this patients would actually increase up to threefold in third trimester, exceeding 500 milligram as compared to 200 milligram in healthy patients, and returns to baseline by third month postpartum. So when there is abnormal increase in proteinuria from baseline, we need to actually exclude causes like preeclampsia and UTI. Diagnostic criteria for AKI, which are again not so firmly based, but acute rise in creatinine by more than 0.5 milligram per deciliter from baseline within 48 hours has been proposed to be defining criteria for AKI in pregnancy. And due to physiological changes, the serum creatinine level of normal allograft function is lower than baseline, which is usually 0.4 to 0.6 milligram per deciliter during first trimester. In normal pregnancy, we usually take it as 0.8 milligram per deciliter, and anything beyond 1 is to be considered as abnormal for normal pregnant females. But in this patients, 0.4 to 0.6 is the cutoff for first trimester. So whenever these patients are having post antenatal visits, serum creatinine is of utmost importance. Hematuria and proteinuria may be used as surrogates along with serum creatinine and reduction in urine output to diagnose AKI or acute kidney injury. Differential diagnosis of AKI are in first trimester hyperemesis gravidarum, septic abortion, and medication related. In second trimester, various reasons like preeclampsia, eclampsia, pyelonephritis, HELLP syndrome, TTP, HUS. In third trimester, again, HELLP syndrome, TTP, HUS, preeclampsia, eclampsia, and recurrent glomerulonephritis. In peripartum phase, majorly PPH, uterine rupture, and obstetric trauma. And in postpartum, atypical HUS, NSH, and puerperal sepsis. Causes of pregnancy-related AKI in this patients. In pre-renal causes, it is hyperemesis gravidarum, heart failure, hemorrhage, liver dysfunction, calcineurin inhibitor toxicity, which is actually one of the agents used for immunosuppression, diarrheal infections, OHSS. In renal causes, immunological, recurrent disease, the list is endless. And in post-renal, there are hydronephrosis or any kind of obstruction on the ureter, or even fibroid and neurogenic bladders. Acute rejection, they mentioned that decreased immune activity of lymphocytes is actually advantageous for mother having kidney allograft. Pregnancy is basically a threat for graft rejection due to alterations in previously stable immunosuppressant regime and risk for sensitization. In absence of risk factors, acute rejection rates are similar to general population. And rates of graft loss at 2 years post-delivery in pregnant kidney transplant recipients vary from 5 to 9%. Anything, any modality to diagnose rejection is not as accurate as kidney biopsy. So renal biopsy, whenever you are having any doubt of acute rejection. Medications, calcineurin inhibitors are gold standard. Lower levels of tacrolimus are to be maintained because there is physiological hemodilution and it is not possible to measure unbound tacrolimus. And very high calcineurin inhibitors would again lead to vasoconstriction of afferent as well as efferent glomerular arterioles, leading to AKI. Proteinuria from mTOR inhibitors, which are again immunosuppressants, would actually exacerbate, resulting into AKI. And antibiotics, antivirals, and antifungals can be nephrotoxic depending on the dose. Risk factors for pregnancy-related AKI are solitary kidney, that is single kidney, susceptibility to volume depletion, immunological risk factors, increase in urinary reflux, increased risk of acute urinary retention, ureteral strictures, exposure to nephrotoxic antimicrobials, and increased risk of viral infections. Diagnostic criteria for AKI, roughly again, once you suspect, blood and urinary test to be done every 2 to 4 weeks in pregnant kidney transplant recipients with stable renal function, controlled BP, and no proteinuria. Whenever there is risk factor present, more frequent follow-ups are needed, and fetal USG need to be frequently done for majorly stability as well as viability. This is the list of investigations to be done every 2 to 4 weeks in patients we are suspecting to have AKI or prone to have AKI, like urine routine micro, quantification of protein excretion, CBC, renal and liver function test, direct and indirect bilirubin, and various other tests. Management of AKI depends on the cause. Multidisciplinary team approach in form of transplant nephrologist, maternal and fetal medicine specialist, transplant surgeons, and neonatologists to be taken into confidence. BP monitoring closely, especially in second and third trimester, and any indication of hypertension would require more frequent clinical visits, and any sign of preeclampsia would require hospitalization and further monitoring. General measures prompt identification, reversal of cause. In pre-renal AKI, IV fluids will be of help. In ischemic AKI due to anemia, blood transfusion will help. In patients with hypervolemia, loop diuretics by taking nephrologists into confidence would be of help, and close monitoring of serum electrolytes, nutritional support, and UTI would be covered by broad spectrum antibiotics for at least 3 weeks. The treatment for rejection was basically dependent on biopsy findings, presence or absence of donor-specific antibody, and history of infections. High-dose steroids were helpful in treating allograft rejection, escalating immunosuppression by titrating dose of calcineurin inhibitors, and at the last, kidney replacement therapy. The outcomes were better in young female, stable graft function with no recent episodes of graft rejection, serum creatinine less than 1.5, proteinuria less than 500 milligram per day, and normal or well-controlled hypertension. Females with preeclampsia had 4 to 11 times more risk of increase in creatinine level, at least 50% in first trimester up to postpartum. And risk of adverse maternal fetal outcomes has been reported to be higher in multiple pregnancies and those pregnancies conceived out of artificial reproductive technologies. And cesarean sections were reserved only for obstetric indication. The next paper was specifically for planned pregnancy in kidney transplantation. Again, a review article published in 2021. Main potential issues they covered were counseling for contraception, maternal medical management, and choice of immunosuppressive management. Increase in 24-hour creatinine clearance by 25% in first 4 weeks of pregnancy, by 45% at 9 weeks, and some decrease in third trimester and small increase in first days of puerperium were noted. Increase in plasma uric acid may predict preeclampsia was their finding. So potential issues which were covered like preconceptional counseling, knowledge of factors that may affect pregnancy success, timing of pregnancy, and possible impact of medical management on maternal and fetal outcomes. Early counseling on contraception, to reduce risk of unplanned pregnancy, improve pregnancy outcomes, reduce maternal complications. IUCD, oral contraceptives excluding contraindication, and subdermal implants were contraceptive methods of choice, and emergency contraceptives to be avoided due to higher doses of progestins, and they actually preferred termination of pregnancy by surgical methods rather than using emergency contraceptives. Factors affecting pregnancy outcomes are rejection, poor graft function, nephrotic syndrome, hypertension, obesity, and other comorbidities. Just to brush it up, main maternal adverse events during pregnancy in this patients were infection. Basically, UTI was actually something which might increase chances of preeclampsia. Pyelonephritis was severe and uncommon complication, and risk of viral infection was elevated. Hypertension, again, was something which would lead to preeclampsia and major risk factor for cardiovascular disease, cerebrovascular accidents, and graft dysfunction. And preeclampsia actually increased everything, MODS, that is like multi-organ dysfunction syndrome. GDM, we know that nephropathy, diabetic nephropathy was more common, and that led to more detrimental results when compared with normal healthy pregnant females. And acute rejection was seen in about 10% of patients, and risk factor for graft dysfunction infection may develop after aggressive immunosuppressive treatment. These are medications and teratogenic effects. Basically, majorly used medications for immunosuppression were glucocorticoids and calcineurin inhibitors, and rest of the medications were actually having little or more teratogenic effects. I'm not going to cover all these medications, but these are the list of medications. mTOR inhibitors again are preferred because they're having lesser chances of teratogenicity. So when it came to mode of delivery, they said vaginal delivery is the safest method. Cesarean section for maternal issues like poorly controlled diabetes, severe hypertension, prolonged labor, and fetal disorders like malpresentation, non-reassuring fetal heart rate, and growth restriction. Caution was to be taken majorly with regards to anatomy of transplanted kidney, because as we know that whenever the kidney transplantation is done, if that kidney fails, a new kidney has to be transplanted at a new place. So the kidney which actually failed stays there. And that is why the path of ureter has to be located by using transabdominal ultrasonography in patients of kidney transplantation. One more paper was pregnancy after transplant, addressing the mode of obstetric delivery among solid organ transplant recipients. It was again a review article published in 2021. No difference in maternal morbidity by mode of delivery was there, and no difference in risk of graft loss within 2 years after childbirth was noted between group of delivery vaginally and cesarean section. But there was a lower rate of neonatal composite morbidity in patients having trial of labor as compared to elective cesarean section. So even this trial of labor patients were terminated by cesarean delivery, they were having lower rates as compared to those patients who directly or straight away were taken for planned or elective cesarean section. One more paper was pregnancy outcomes in females with transplant, kidney transplant, meta-analysis and review article. So basically, this particular study is the last one, which was published in 2019, and they actually found out around 1,500 of articles, but for their own purpose, they had found 87 studies which were of use. The results were mean maternal age was around 30 years in those studies. Live birth rate was around 72% in those patients having kidney transplant. HDP was noted in 24.1%, preeclampsia in 21.5%, and GDM in 5.1%. Preterm rate was 43.1%, ectopic 2.4%, and cesarean section rate was around 63%. Mean gestational age was 34 or 35 weeks, and mean birth weight was around 2.5 kg. Higher neonatal mortality and lower live birth rates in pregnancies within 2 years of transplant as compared to ones after 3 years. So whenever the pregnancy was planned within 3 years, they had higher neonatal mortality and LBW cases as compared to the pregnancies which were planned after 3 years of transplantation. And spontaneous abortion rates were higher in extremes of age, with maternal age less than 25 or more than 35, as compared to the group which had actually maternal age between 25 and 34 years of age. So these were the studies I tried to find, in last at least 4 to 5 years, which actually tried to cover up a lot of saline features of pregnancy with kidney transplant and not to have any overlap. Thank you. Thank you so much.
Wonderful presentation, Dr. Manjal.
Thank you.
I think your presentation must be a,
it must be a choice for collection. I mean to say it is a presentation worth corrector's choice. You have
Okay, ma'am.
reviewed all the recent articles so beautifully. I'll just summarize what obstetrician should know. Great messages you have conveyed. I just want to say that reproductive function in women with end-stage disease generally improves after kidney transplant. However, pregnancy remains challenging due to the risk of adverse clinical outcomes, and fetal-maternal risk, both are there. So we need very good sessions of patient counseling and clinical decision making whenever these mothers are planning for conception, these transplant recipients, because we know that there are so many obstetrical risks involved. PIH is so high, preeclampsia is so high. Around 25% patients develop this. Then there are more chances of low birth weight babies, preterm deliveries, stillbirth, cesarean chances increase, preterm delivery is there. And before these women embark on pregnancy, they should be switched over to safer immunosuppressant, which are calcineurin inhibitors like tacrolimus or cyclosporin. We have explained it very well. And we should be very, very careful in monitoring the pregnancy closely by regularly following them with the serum creatinine and everything. So these things are important, and you have highlighted how to judge acute kidney injury. That is very, very important, and we can do it only by close monitoring. So thank you so much. And if Jaya ma'am wants to add anything, Jaya Rani ma'am wants to add anything.
Yeah, that was a very nice presentation, Dr. Munjal, and it is really throwing a lot of lights on nowadays as people are coming with a renal transplant, getting pregnancy, getting IVF treatment. It is a real challenge for us to look into all the intricacies. And you have shown up a nice, all the collections about these factors in your presentation, which is very nice. And really, it is a very interesting factors in an upcoming treatment for the fertility IVF specialists, especially to look into all the complications they go through, and it needs a lot of counseling and a lot of close monitoring, which is very important, as you insisted. It is so nice that you have presented. It's very nice. It's seen every journal you have taken everything from every searches you have made.
Ajay ma'am, I'm working in a public sector or hospital. Even we are getting these renal transplant patients with pregnancy. They are coming because it has become so this thing, and
so common. Yeah, nowadays it's so common. That is the reason that we are getting a lot of patients.
Yes, I think it was a most newer topic and a very well means a topic which is not discussed so much in depth. And that was the idea keeping. And Munjal, I think you have removed the rich, actually it was rich with the clinical evidence, the whole presentation. I had so many, everything, how the comparative and studies, what you showed about the outcomes. I'm not going to repeat all those, but you highlighted such important points. We are really worried and dilemmatic. Some patients coming to us, in tertiary center telling that, yes, I have a renal transplant, I want to get pregnant. And then you need to counsel them. You need to know, what is going to happen, what is going to be the due course, prepare them. And I think it highlighted every aspect. So excellent presentation.
Risk of graft rejection. Yes, ma'am. Risk of graft rejection looms large.
Everything. We need to explain to them everything to our pregnant patient, because we want them to know the pros, cons, everything. So I think it highlighted very well. Great justice done to the topic.
Well, ma'am, that is why we want to prevent non-communicable diseases, because all these things are leading us to renal failures and more this thing, renal transplant. So we should be ready with all this. Thank you, Munjal. Thank you so much.
Thank you, Anita madam. Thank you, Jairani madam, and thank you, Komal madam, for the opportunity. You always showed a huge trust in us, and thank you so much for all the opportunities that you have been giving, ma'am. Thank you so much, ma'am.
Yes, nice, Komal. Thank you, Komal. It's so nice for interviewing me. And I have a great pleasure and pride to be in a part of your wonderful ask and task, and that is a very important one that you have with your series of AGs, and it is very nice that you have covered mostly from jaundice. It is almost any postgraduate who is sitting here who would have watched this would have been absolutely benefited with so much of clinical knowledge about how to manage a jaundice, which you have made it so simple, straightforward, and made very clear with your panel. And it's really, I enjoyed it. It's so
Thank you,
nice.
thank you. I request the chairpersons to just
Yeah.
hold on. We have one more and Dr. Shefali Jain to join. I welcome her also. Pradnya, yeah.
Yeah.
We welcome
So,
her and then
Dr.
we have one more
Shefali Jain,
last.
there was, yes. She's a consultant and head Department of Obstetrics and Gynecology at BJ Hospital Research Fund Institute from Gondia. We welcome you, madam. I request you to introduce our last speaker, Dr. Amrita. She'll be speaking on kidney disorders and abnormal uterine bleeding. Dr. Shefali, if you could just introduce Dr. Amrita.
So I'll just.
hear me?
She's there.
Yes,
Yeah,
ma'am.
yeah, she's there, ma'am. She's there.
Oh, okay, right.
Our next speaker, welcome, madam, Dr. Amrita Pentakote. She is a junior consultant in Apollo Credit and Children Hospital, Bangalore. And she has presented in multiple national, international forums. She won second prize for poster presentation in South Zone Yuva Foxy 2020. She has
I think her net is unstable. Yeah.
Journal of Obstetrics and Gynecology, India. Welcome, madam, for the next topic, Dr. Amrita.
Thank you, ma'am. A very good evening to you all. It's an honor for me to be a part of this session today and, share the stage with you all, big dignitaries. I'm a very small person next to you, but I would like to do my best. So I would like to share my screen.
Madam, very well thought of topics. You made us, read all of them. Kidney disease and AUD is another, another side of the coin.
Yes, and we have our young, dynamic, dashing Amrita going to now throw a light on this topic.
Is my screen visible, ma'am?
Yes, we can see you.
Yeah, well
Screen
seen.
also, yes.
So I'll be doing a journal scan on kidney disorders and abnormal uterine bleeding. As we all know, there is very limited data available on this, but whatever recent is available, I tried compiling and presenting today. Introduction into the topic. Disruption in the hypothalamo-pituitary-ovarian axis is noted in chronic kidney disease, which results in an abnormal reproductive hormone profile. The pulsatile release of GnRH is impaired in kidney failure, resulting in lack of FSH and LH cyclicity. Consequently, estradiol levels stay relatively low, inhibiting the surge and ovulation of luteinizing hormone. Elevated prolactin levels, owing to reduced clearance and increased production, also contribute to anovulation. Let's register this last point as I have something relevant a little later. Now, the major question in all of our minds right now is, how are menstrual abnormalities among women with CKD, the chronic kidney disease? I will be discussing a meta-analysis published in 2022, December, by Ritz et al. On menstrual abnormalities and reproductive lifespan in females with chronic kidney disease, a systematic review and meta-analysis with the objective. Menstrual abnormalities and shortened reproductive lifespan are associated with shorter life expectancy, higher cardiovascular and osteoporosis risk in the general population. Although the magnitude of these reproductive factor irregularities in females with CKD is unclear. Coming to the methodology, various databases, Medline, Embase, Sinal, have been used to retrieve the data from the time of database inception to February 22, the data has been taken. It includes all the original articles talking about females of reproductive age with non-dialysis dependent and dependent non-kidney transplantation and menstrual patterns, age of menarche, and or menopause. 46 studies have been identified and 35 were meta-analyzed. The results are basically discussed on these three aspects. What are they? Menstrual abnormalities in non-dialysis, non-transplant dependent population, menstrual abnormalities in dialyzed females, that is hemodialysis plus peritoneal dialysis, menstrual abnormalities in transplanted females. Coming to the menstrual abnormalities in non-dialysis, non-transplant dependent population, inadequate data from all the studies have been noted. Hence, the global assessment of menstrual abnormalities in this group could not be gathered. However, menstrual abnormalities in dialyzed females, 18 studies were taken, and in this, 63% women have been noted to have menstrual abnormalities with a significant p-value of less than 0.001. Now, coming to the stratification on menstrual abnormalities in hemodialysis group, 47% have been presented with irregular menses, and polymenorrhea and oligomenorrhea being 19% each. Amenorrhea was presented in 41% women. Now, coming to the forest plot, the meta-analysis has been described here in the form of forest plot. As we can see, in terms of amenorrhea, the diamond here is touching the null line, which implies that it is not significant. However, when we come to oligomenorrhea, polymenorrhea, and irregular menses, these diamonds, which are the pooled means, are not touching the line of null, which indicate that these have got significance, statistical significance. So, as we know, as we have already seen, the percentages of amenorrhea, oligomenorrhea, irregular menses as are this. Coming to menstrual abnormalities in peritoneal dialysis group is studied less. From the available data, menstrual abnormalities were recorded in 75% population, which is pretty high. Menstrual abnormalities in transplanted females. Coming to this, as we can see, amenorrhea in pre-transplantation group was 39.32%. As we see in post-transplant group, there is a drastic fall of to 8.01. When it comes to oligomenorrhea, in the pre-transplantation group, 20.53% presented, 20.53% women had oligomenorrhea. After the transplantation, there was a drop to 17.83%. 7.39% women had polymenorrhea pre-transplantation, and there was a slight increase to 10.23 post-transplantation. Coming to irregular menses, 38.37% had irregular menses pre-transplantation, while 32.42% had irregular menses post-transplantation, which is again a slight decrease. Kidney transplantation was associated with 7 to 30% decrease in menstrual abnormalities overall. Coming to the forest plot, again, it is visualized clearly. Here, the prevalence of pre-transplantation, as we see, the weights are here on the right side. As you come to prevalence post-transplantation, they're all shifted to the left side, which is between the 0 to 25% prevalence. The same is noted with oligomenorrhea and irregular menses as well. Now, conclusion of this study was menstrual abnormalities and shorter reproductive lifespan are common in females with chronic kidney disease. Kidney transplantation may improve the menstrual health. So, what do women on dialysis and post-kidney transplantation have to face? To answer this question, gynecological follow-up of 129 women on dialysis and after kidney transplantation, a retrospective cohort study of 10 years has been performed, and it was published in 2015 with an objective to describe the gynecological issues and follow-up in a referral center of women on dialysis and after kidney transplantation. The methodology was, it was a retrospective cohort study. 129 dialyzed women were taken, among whom 102 people had undergone a transplant. It was a follow-up study for around 10 years. Menstrual patterns, pregnancies, contraceptions, and cervical cytology were studied. Now, coming to the results, it is quite evident here. Regular menstruation was observed in 78.7% people before dialysis. When the dialysis was started, there was a drastic fall to 30.6%. And after transplantation, there was a steep improvement to 57.1% in the regular menstruation with a significant p-value. Coming to amenorrhea, on dialysis, there is a huge number of 43% women presenting with amenorrhea. After transplantation, there is a drop to 23.1%, also being statistically significant. Coming to metrorrhagia, there were 17.1% women had metrorrhagia before dialysis, and on dialysis, it increased to 25%, and after transplantation, it increased further to 30.5%. Coming to inflammation on smear test, before dialysis, it was minimal to 0.8%, and after transplantation, it is huge 33% with statistical significance. Intraepithelial neoplasias were noted in 2.3% women before dialysis, and after transplantation, it was hugely gone up to 12.6 with statistical significance. The conclusion of this study was women on dialysis and after kidney transplantation suffered more from abnormal uterine bleeding and metrorrhagia. High rates of abnormal smear tests were noted. This population needs a close follow-up to identify and treat gynecological issues. Now, coming to this topic, we understand that most of these ladies go to see the nephrologist more than the gynecologist, because the main concerning factor here is the chronic kidney failure. So, what is the role of nephrologists in this particular aspect? Are nephrologists adequately addressing to the impact of chronic kidney disease on sex hormones in women? Coming to this, Canadian Journal of Kidney Health and Disease has published an article in 2017 stating sex hormone status in women with chronic kidney disease, a survey of nephrologists and renal allied healthcare providers' perception, with the objective to determine nephrologists and allied healthcare providers' perception on management of sex hormone status in women with chronic kidney disease. Methodology, it was an internet-based survey. Nephrology Society members were sent the survey. It included both nephrologists and renal allied healthcare providers. Across the countries like Canada, Australia, New Zealand, and United Kingdom, the survey was sent and the data was extracted from February to November 2015. Reported perceptions and management of sex hormone status in women with CKD was studied. Results were something like this. It is astonishingly high that 95% nephrologists agreed that kidney function impacts sex hormone status. However, a minimal of only 35% nephrologists discussed fertility with these women, out of which transplant nephrologists, which were 53%, and non-transplant nephrologists were 30%. Allied healthcare providers were 7.5%, and it is carrying a statistical significance. It's a minimal of 15% nephrologists who had discussed menstrual irregularities, and it is addressed very less, even less by allied healthcare providers, and it also has a statistical significance. So what we understand from this is nephrologists and allied healthcare providers, though they recognize the impact of CKD on sex hormones in women, but report not frequently discussing sex hormone related issues with patients. Now, coming to something, a newer advance in research, this is hyperprolactinemia, a prognostic factor for menstrual disorders in female adolescents with advanced chronic kidney disease. So as we have noted in the introduction, I had said there's hyperprolactinemia because the clearance is less. So this factor has been used as a prognostic marker for surveillance after kidney transplantation. So yearly the prolactin levels are noted. As the hyperprolactinemia is coming down, it is noted that the menstrual regularity is improved in these women. So it is still in the process of research. These are my references. Thank you.
So wonderful presentation, Amrita. This was a beautiful review of literature of current presentations you had. We must understand, why does chronic kidney disease lead to irregular cycles? What happens is that there is basal secretion of gonadotrophin releasing hormone, but the pulsatility of the release is decreased. So mid-cycle LH surge is not there, thereby leading to anovulation. So these females have usually anovulatory cycles, and thereby they are having irregular, menstruation and infertility for that matter too.
Yes.
Now it has been seen that majority of women who present, they were either in stage 3 of renal failure or something like that. But definitely, as highlighted by you, kidney transplantation improves their fertility also, and irregularity of cycles also gets better. So many start menstruating after getting kidney transplantation done, which the females which were amenorrheic previously, now they start menstruating. So all this physiology is important, and it is also said that endorphin excretion is also reduced. So there is, imbalance of these hormones leading to inhibition of ovulation. So all these things are important. And one important thing is, Amrita, you have also highlighted in your one of the slides, is because there is anovulation, there is no progesterone. So these women might have CA in situ, or CA endometrium have also been reported. So we have to be very, very cautious in these patients. So over to Jairani ma'am, if you want to add anything.
Yeah, that was very nice. So I just want to ask you one question. What are all the studies, the age group of the patients, Amrita? Because I couldn't find the age limit. What are the age limit of these women?
Ma'am, whoever presented with chronic kidney disease have been studied, irrespective of the age. So the menstrual irregularities, the reproductive fertility aspects, and the menopausal status have also been studied. I've been precise about the abnormal uterine bleeding, so it's an extensive study. Yeah, all the people with chronic kidney disease were included, ma'am.
All right. Okay, that's fine. So it is very clearly you have discussed everything about what are the practical things that we should look into these patients, how a transplant improves their menstruation, their ovulation, and even restore their fertility, which is a very important point that you have searched in your searches and you have given. And that is a very good, good way of giving us an insight about how the fertility will be affected, or what are things that we have to look into them, and how we can plan their fertility approach when a CKD patient comes to us seeking for an IVF or a fertility treatment. That's so nice. You have covered everything about the CKD and the irregular menstruality, ovulation, as well as their fertility also. Nice, Amrita.
Thank you so much, ma'am.
Yeah, early menopause was also reported, which the statistics got improved by renal transplant. You have highlighted each and every point. Congratulations. Thank you, Komal ma'am, once again.
Thank you, Komal. Thank you, all the coordinators.
Excellent presentation. I think you have done the complete justice to the topic, because this is really a newer aspect which we are trying to analyze, and it has opened a newer thing. Like, we need to know the reproductive career of this woman with kidney disease. So this is very important, because the treatment and what is going on at the studies are very important, because that forms the basis of our counseling, our further management of patients. And I think both the journal scans have highlighted so well the studies, and it is going to open a new insight in our management and approach to these cases. So I thank you, all of you, all the chairpersons for chairing, Dr. Anita, Dr. Jairajani, Dr. Shefali. I think you all have been here. Our lovely coordinators, Dr. Pradnya and Ruchika, they have done a fabulous job. And Munjal and Amruta, flawless, very good. I think you all have done a complete presentation and a well thought journals, and I think it is really becoming more interesting than hearing to those topics which we speak very often. So I think this was a lovely thing which I really enjoyed, and I was sitting all throughout and listening to your talk in detail. So thank you so much.
So anyhow, Komal, the credit goes to you to choose this topic, to give the correct person, correct way to talk, and they are really superb in doing their topic the great justice.
The beauty of their presentation was that they highlighted all the clinically relevant points.
That is what we needed for the practice.
Tables and statistics. That is what an obstetrician should know.
Yeah.
Congratulations to both of you.
Yes.
Munjal and
and my two coordinators, they are also really work very hard. Dr. Pradnya and Dr. Ruchika, I would like to thank them. And our
Thank you, madam.
For this platform. I think without thanking them, we cannot end the webinar. And at the end, I just want to know JNK stands for Jairajani Kamraj. So we have
yeah.
It was just in my mind.
That suits it.
I think this is just a coincidence. This was not thought of anything.
Yeah.
It's happening for the good. So with that note, we would end today's episode. And we are well in time today at 7, and we would log in again next Wednesday for the next episode. So thank you all. Thank you so much. Bye.
Thank you so much, ma'am.
Thank you, Komal. Thank you.